call upon Dr. Sonal for discussing the benign retinal and choroidal tumors here. Dr. Sonal did her fellowship with Dr. Santosh Unava sir, CFS Hyderabad. Then she was with Dr. Paul Finger, New York. She also has written one large open access book on all the tumors, which is very much available on the internet. And presently she is at HV Desai and she has her own center in the Pune. Welcome, Sonal.
Thank you, Dr. Sumit, for the kind introduction. I think both of our prior speakers have opened up an atlas of eyelid and ocular surface tumors in front of you. So what I have done is I've chosen a few lesions which we commonly get to see in routine retinal examination. So the beauty or the point of these lesions are they are hardly symptomatic. So hardly the patient is going to come to you with anything specific. These are the lesions you might just find while doing a complete examination, a complete dilated examination. So again, to reinforce the importance of a dilated fundus examination, even if the patient has come for an anterior segment complaint or just a routine workup. So ideally, the fundus examination has to happen annually for every individual. So that is when you get to spot these lesions, diagnose them, label them, and then monitor. Because more often than not, the treatment is going to be monitoring. So with that, let's go on to a few of these colored lesions. So most of these lesions I'm going to talk about are going to be pigmented. Where does the pigmentation come from in our intraocular tumors? So the primary intraocular pigmented lesions can be either from your melanocytes of uveal tract or from pigmented epithelium. So we are going to cover a few of these lesions, including congenital hypertrophic retinal epithelial, hypertrophy of retinal pigment epithelium, RP hematomas, a combined hematoma of RPE and retina, and optic nerve head melanocytoma. So basically, where does the pigmentation come from? Specifically, if you talk about retina, there can be atrophy of cells, hypertrophy of cells, or hyperplasia of the pigmented epithelial cells, which is going to give rise to these colored appearances. So either a migration, increase in number of these cells, or migration of these cells and metaplasia, or exaggerated hypertrophy and hyperplasia are going to give you these appearances. So this can either come from infections, post-infectious scarring, or tumors or trauma. So be careful while you're examining any pigmented lesion. Look at the associated features as well. So coming to a common entity, so we commonly call it as a CHOPY. This is a congenital hypertrophy of retinal pigment epithelium. So the common types it can be divided into are solitary, grouped, or multiple CHOPYs, and atypical ones which are known to be associated with familial adenopolis. So coming to solitary CHOPY. So this can be a well-demarcated, flat to minimally elevated plaque-like lesions, which can range from black homogeneous lesion, typically with a depigmented lacunae, to a completely depigmented or a full with lacunae lesion. So coming to a solitary CHOPY, so you will see the stuck-on appearance it is giving on the retina with very well-defined edges. Sometimes it looks like this as a completely pigmented lesion, or sometimes you can have these halos or lacunas, which is also a characteristic of the solitary CHOPYs. The common conditions this can be confused with is a peripheral choroidal nevus or choroidal melanoma. Those are the conditions you have to differentiate this from. So what puts this apart is these lesions are found mostly in the mid-periphery to periphery. And if you go on doing further investigations, you will definitely be able to differentiate it from nevus or melanoma. So these are congenital. Though they are congenital, diagnosed median age of diagnosis is around 45 years, because these are incidental findings in an asymptomatic patient present in mid-periphery or periphery. They can be well demarcated, minimally elevated, a homogeneous lesion, typical depigmented lacunae, which we just spoke about, can have slow, gradual growth in its peripheral diameter. Though not alarming, but 2% of them can have a nodular growth, which can lead to an RP adenoma or adenocarcinoma in future. So So how do we differentiate? So if you look at the ancillary testing commonly done for fundus fluorescence angiography, you will be able to see the blocked fluorescence and retinal vessel crossing above it. Will help you differentiate it from the choroidal pathologies, which will kind of show their own vascularity as well. OCT will show loss of photoreceptors, the subretinal clefts, which we call, and increased transmission through the lacunae, which will help you label these lesions. So what will you do after labeling these lesions? The most commonly applied treatment is periodic observation. If you do have a lesion with a small nodular growth, if it has given rise to some exudation or subretinal fluid, laser photocoagulation or cryotherapy, because these lesions are far in periphery, will work well. Or if there is surface wrinkling, retinopathy, and a lesion representing macula, vision threatening component, you can also add vitrectomy and membrane peeling for the same. So how about these ones? They are the multifocal or grouped Chirpys or beer tracks, they are called, because of the small combined appearance. So these are several groups of well-defined flat slate gray lesions. They usually assume a sectoral distribution. They are present together. Each group can consist of around 3 to 30 individual of these pigmented lesions. The diameter can vary from 0.1 to around 3 millimeter. With the larger lesions located more peripherally, smaller lesions are located more centrally. But these tend to lack the lacunae which are present in a solitary Chirpy, can be minimally elevated. They can also be polar beer tracks, which are the non-pigmented lesions. So the entire sector can be non-pigmented. You can call them as a polar beer tracks, being white beers. These are essentially stable lesions. So which are the lesions you need to be concerned about? Though, Dr. Sumit wanted me to cover the lesions not to be worried about, but in every lesions you do need to be wary of some points. So these are the atypical ones which are associated with familial adenomatous polyposis and Gardner's syndrome. So 70% of patients with familial adenomatous polyposis can have these lesions. These are multiple and bilateral. How they differ from the classical Chirpys, they have less defined margins. They are randomly distributed, not sectoral in distribution. Can be pinpoint to more than 100 in number. So this condition has a strong association with FAP and an autosomal dominant condition in which 100% of the patients can develop colon cancer. So including the patient, the entire family needs to undergo routine colonoscopy to rule out any presence of polyps in their intestines. So again, management is periodic observation. Close association of FAP and colon cancer has to be kept in mind and reminded to the patients to keep under routine follow-up and systemic investigation. And as I described, the periodic colonoscopy and removal of suspicious polyps for individual or family is of utmost importance to avoid progression of the disease. Small note regarding RP hamartoma. So again, another incidental findings. You just might find them while routinely examining a fundus. These are distinct solitary nodules, can be less than 1 millimeter to 1 to 2 millimeter in diameter, and 1 to 2.5 millimeter elevation can also be there. So just because something has an elevation or something has a 3D configuration does not mean it has to be worrisome. These hamartomas can also have significant thickness. They tend to be in central macular location. Minimally dilated retinal feeder vessel and mild adjacent retinal traction and vitreous pigment cells are also been described in association with the RP hamartoma. So how can you examine it further? Is with the help of OCT. It will show an abruptly elevated solid mass within the retina and a complete optical shadowing because of the pigmented and solid nature of the disease. So the OCT helps in monitoring these lesions and exactly knowing which layer the disease has penetrated to, if at all there is any progression. Another interesting one is a combined hamartoma of retina and RP. This is also very important differential diagnosis of leukocoria when you are examining pediatric age group patients. So these tend to be congenital, non-hereditary. The diagnosing age might be around 10 to 14 years of age, depending upon where the lesion is situated, how much visual disturbance it has caused to seek medical attention. They can vary widely in size, ranging from small 1 millimeter diameter mass to lesion greater than 10 millimeter. So they tend to be these gray retinal masses that demonstrate tortuous and straightened retinal blood vessels, probably due to the secondary retinal traction from the excessive gliosis on the surface of the lesion. They are characteristically located along, on or adjacent to the optic disc. A peripheral lesion can also cause retinal dragging, creating a drag disc appearance. Such combined hematomas can be associated with peripheral retinal ischemia and secondary peripheral neovascularization. They can be completely isolated. However, some association has been found with neurofibromatosis too because of the inherent gliosis these pathologies have in common, Gorlin syndrome as well as branchio-oculofacial syndrome. So if you go ahead and do a fundus fluorescein angiography, the dragged appearance and retinal traction bands are very, very visible. OCT will help show an irregular lesion with retinal traction into a sawtooth or a folded pattern as visible here. So that is what is replacing the entire thickness of the retinal tissue over here. So management-wise, there is no highly effective method for treating any of these lesions. For children, amblyombic therapy can be helpful for vision restoration. A vitrectomy and membrane peeling can be helpful in cases with vitreous hemorrhage or a preretinal gliosis. But however, if the lesion involves the full thickness of retina, there is nothing much you can do about it. OCT can help determine the depth of the lesion and can help which patients may benefit from this intervention. However, rest need to be monitored for their presence. And the laser photocoagulation can be employed for rare neovascular membrane that can develop on top. Moving on to, I think, one of the last lesions. So this is an optic nerve head melanocytoma. So melanocytic hematoma or hyperpigmented magnocellular nevus of optic disc is the optic nerve head melanocytoma. Many a times get confused with the choroidal melanoma, or not confused, I would say. You need to differentiate it from choroidal melanoma, juxtapapillary choroidal melanoma. Because again, the treatment over here is going to be observation. So what I feel is observation and monitoring is actually the most difficult decision to make, because you're not intervening, you're not taking out any tissue, you're not doing anything. So you have to be really sure about your diagnosis before not doing anything about it. So always be thorough with the investigations. All of these lesions can be investigated thoroughly with ancillary testing available in all of the ophthalmology clinics. So these patients tend to be around 50 years of age averagely, can be unilateral, mostly unilateral. 25% patients can present with visual loss because of subretinal exudation or fovea, neuroretinitis or CRBO, or a malignant transformation which occurs in less than 1% of patients. They do present with RAPD very classically because of the optic nerve affection and also visual field defects. They can show growth over a period of time, so don't be alarmed just because there has been a growth. However, it needs to be a slower growth. The growth can be either on the retinal side or also on the optic nerve side, so periodic MRIs are also important. If you do a perimetry, you would find that these patients do have visual field defects and enlargement of their blind spot. So minimal to extensive enlargement is known to find. And a nerve fiber bundle defect related to absolute arcuate defect can also be found. On OCT, they tend to have this particular halo beneath the layers, and you can actually see small melanocytic cells being picturized in the perilesional vitreous. They do block fluorescence on FFA. So FFA, OCT, and ultrasound B scan and periodic MRI can be the tools you use to periodically monitor these lesions. So again, periodic observation, small degree of growth can be observed. A more progressive growth or a profound visual loss or a probable malignant transformation, enucleation and histopathology is the way to go. So to summarize these lesions, you can look at the shape, color, number of these lesions, how they are placed and their borders, location, particularly macular and extramacular. That will give you a gross idea about how to label these lesions. So once you have examined, investigated and labeled these lesions, then you can go on monitoring and following up the same patients. So I've, in interest of time, and I'll stop here on completing the retinal lesions, and I'll hand over to Dr. Mritika to take over for the malignant retinal lesions. Thank you.
Thank you so much, Dr. Sonal. And just till the Mritika sets in, I would like to ask, what do you do for those optic disc melanocytoma generally? How often you observe them, and what is the protocol that you follow?
Yeah, so the first So at the first visit, you do a complete thorough examination, including your fundus imaging. So imaging and documentation is the key here because that is how you're going to monitor them in the future. OCT, ultrasound, and an MRI is very, very important, and visual field, perimetry for visual fields. So I like to see them every 3 monthly for the first year, and repeat the perimetry every 6 monthly, and also give them a list of warning signs to come back in between the scheduled follow-ups for if at all they notice any sudden change in vision or any other characteristics. And then later on 6 monthly for another couple of years, and then can monitor yearly for any growth if at all seen. I think I have a few patients who are under monitoring, and they were all diagnosed very incidentally. So the only thing is, again, for your back of the mind diagnosis is ruling out choroidal melanoma. How much ever investigations you do, you still just need to have that little this thing of thread of suspicion, and look for any characteristic you find similarly. Thank you for the opportunity.